Thank you, everyone, for joining this session. So now we're going to do the research posters. So my co-host for this session is Denise. She's a principal researcher at the Health Economics and Epidemiology Research Office. And I think we will start. So each presentation is for 8 minutes, and we allow 2 minutes for questions. So I will just start the timer, and then you can start if you're ready.
Okay, good afternoon. I am Dr. Thameshnie Govender. I am a medical officer in the Department of Pediatrics at Prince Mshiyeni Memorial Hospital. Today, I am excited to highlight our initiative to create a comfort room to enhance family-centered care in the neonatal nursery. Family-centered care is essential in neonatal practice, and as emphasized by O'Brien, it involves parents as partners who enhance kangaroo mother care, bonding, emotional well-being, prepares families for discharge, and fosters better communication in the neonatal intensive care unit. Frequent and meaningful interactions with parents and family members is essential and needs to occur in a private and respectful place amidst a busy neonatal nursery. Through observational assessments, we identified the following problems. There was no private, respectful, family-friendly space for counseling and sensitive conversations in the neonatal nursery. There were no counseling tools and lack of available guidelines for sensitive discussions. There were no formal teaching or training for our staff. Mothers and staff experiences and perceptions regarding their counseling environment was not explored. Our objectives were clear: to design and implement a comfort room within the neonatal nursery that will provide privacy, dignity, emotional support, and cultural sensitive communication. To ensure counseling tools and aids are available to our staff, and teaching and training of our doctors. Also to evaluate the experiences of staff and family members after implementation of the comfort room. Our methods include repurposing of a storage space for the comfort room. The room to also include a calm environment with soothing colors, comfortable furniture, and culturally appropriate materials. And that would be your mural themes, the tree of life, and pastel colors. There would also be a provision of brief guidelines, counseling tools, and policies to standardize sensitive discussions with families, and these were provided from Patch SA. Implementation was supported through presentations to help apply the tools during counseling sessions. Informal interviews collected feedback from families and staff during the first month of the room's inception. Our evaluations focused on the care experience and the emotional support and overall satisfaction. Our results were encouraging. A comfort room was established in the neonatal nursery to provide a respectful place for all family counseling sessions and addressed a major flaw in the holistic neonatal care. A file with the necessary tools and aids is available to all staff who access the room. And you can also scan the QR code on the poster to access these guidelines on perinatal and neonatal counseling from Patch SA. Positive feedback was received from both parents and staff. Families encouraged or emphasized better emotional support. And the healthcare worker, being our doctors and nurses, suggested there was improved privacy, there was zero interruptions, and increased rapport. In conclusion, our comfort room is a simple yet impactful innovation in family-centered neonatal care. It enhances privacy, respect, cultural sensitivity, and holistic patient support. This initiative aims to strengthen compassionate care practices, and it provides a replicable model for pediatric units and identifies opportunities for ongoing improvements through sustainable parent-staff surveys and audits. Thank you for your time.
Thank you, Pranesha. Do we have any questions for Pranesha?
Nozipho, maybe before the next presenter gets ready and we introduce, can I ask a quick question about, you mentioned that you repurposed storage space. So I was just curious about the cost to repurpose the storage space, and kind of who provided the materials and the furniture and the paint and things like that. Was it something that the facility provided, or did you have to get like external funding for that?
Okay, so it was a low-cost intervention because the furniture was existing in the department. So we just repurposed it to this room, the storage room, which was underused. And I think the largest investment was time and to orientate staff and training. But in terms of the decor, that was actually a low-cost intervention. And in terms of who we informed, it was the operational manager of the nursery. We informed her of the setup and how it would support our work. And I think the more we collaborated, the more it was accepted.
Excellent, great, thank you. Well done. Sorry, go ahead.
I think we have another question from someone in the they've put the question in the question and answer session, but you can go ahead and ask. You can switch on your mic and ask the question.
Hello, good afternoon, everyone. Are you able to hear me?
Yes, I can.
Yeah, my question is actually about space. Being a comic rep from a province, we do meet other provincial representatives nationally, and overcrowding is one of the issues in neonatal facilities across the country. So how are you able to get enough space where this kind of intervention can really be done, and how sustainable do you think it can be in the next 2 to 3 years? Thank you.
So this space was actually an underused storage room, and it was adjacent to the nursery, and it allows parents easy access without disrupting clinical outflow. And this room also required minimal cost and minimal structural changes. So it was an already existing storage room that was underused.
Okay, thanks.
All right, thank you for that. Thank you for answering the questions. Now we can go to the next presenter.
Okay, great. Thanks so much. So good afternoon, and thank you for the opportunity to present my MMed research. My name is Stacey Fourie, and this project is titled Tiny Voices, Big Questions, a review of palliative care provision to patients and their families at the end of life at Red Cross War Memorial Children's Hospital. So I just want to begin by recognizing the tremendous dedication of the Red Cross staff. The study wasn't about criticizing the care being provided, but about better understanding the pressures and complexities involved in supporting children with life-limiting conditions, and to use these insights to help build more equitable and holistic pediatric palliative services, to strengthen the systems that support you and to improve the experiences of the families we care for. So just a little bit of background. We all know that children with life-limiting conditions are among the most medically and emotionally complex patients we see, and they have unpredictable disease trajectories and high symptom burdens and recurrent admissions. In the Western Cape, most of these children are managed at Red Cross, and should they need specialist palliative care, they'll be referred to the PedsPal team. In terms of the broader context, nationally, fewer than 5% of children needing palliative care actually receive it. There are a number of challenges facing PPC provision in South Africa, namely late or absent palliative care involvement, limited specialist availability, limited resources and trained staff, poor coordination of care, variable access to psychosocial services, inconsistent advanced care planning, and the PICU as a default site for death for most of these children. And these deaths are often associated with highly intensive interventions that may not align with comfort-focused goals. And finally, a lack of hospice facilities. So in terms of the study, the aim was to evaluate how palliative care principles, including symptom management, ethical decision-making, and psychosocial support, were integrated into the care of children who died at Red Cross in 2022, and also to identify which of these children may have benefited from hospice services, recognizing the current lack of pediatric hospice facilities in the Western Cape. In terms of methods, we conducted a retrospective descriptive study reviewing the medical records of all children under 18 who died in Red Cross during the year 2022. And we excluded those who died within 72 hours of admission due to acute, potentially curable conditions. Just in terms of the variables that were captured on the data sheet, we captured demographics, the ACT classification, date and diagnosis of death, whether the patient was referred for specialist care to PedsPal, where within the hospital the patient died, how much of, or the proportion of the final 6 months of life that was spent in hospital, and the length of the terminal admission in days, what counseling was documented, what support was identified for the family, whether a multidisciplinary team meeting took place and who attended said meeting, whether there was a documented advanced care plan or intervention level in the folder, if the patient died in the PICU, whether there was a do not resuscitate order at time of death, and whether the patient died following withdrawal of life-sustaining therapy, what pain and symptom control was provided in the last 72 hours of life, what interventions took place in the last 24 hours of life, what bereavement support was provided, and finally, we tried to identify patients that would have benefited from care in a hospice facility using the admission criteria from Sunflower House, which is a well-established 14-bedded inpatient hospice unit in Bloemfontein. So on to results. Out of the 157 pediatric deaths at Red Cross in 2022, 126 patients met the inclusion criteria. 43% of these children were referred for specialist care, and of those referred, 1/3 were referred within the final week of life, and a small number on the same day as death. This suggests that specialist palliative care is frequently engaged late and limits opportunities for comprehensive support. Late referral patterns are widely documented in PPC internationally, and this often relates to illness unpredictability and competing clinical priorities. Some key characteristics of our cohort: congenital heart disease was the most common underlying condition. Infants under 1 year accounted for the largest age group, and almost half the cohort fell into ACT category 1, where curative treatment is possible but often unsuccessful. And this group frequently benefits from early integrated palliative care due to a pattern of repeated crises and difficult decision-making moments. Yet our data shows that this does not consistently occur. 54% of the children died in the PICU, and children spent on average 38% of their final 6 months in hospital, and the mean terminal admission was 23 days, highlighting the intensity and burden of medical care near the end of life. Hang on, sorry. Okay. In terms of age, I already covered that the highest proportion was in children less than 1 year old, comprising 41% of the cohort. The leading cause of death was congenital heart disease, followed by oncology and infectious diseases. In terms of the additional support that was offered to these children, 85% of families received at least one additional supportive service, 70% received bereavement support, and this variability suggests that there's room for more structured pathways and more consistent follow-up. Symptom control was provided in most cases, but 11 children actually didn't receive any symptom relief despite clinical indications. Multidisciplinary team meetings were sparse, only occurring in 37% of patients, and there was very limited representation of allied health or nursing at these meetings. And ACP documentation was very low. Only 12 children had an ACP. And then on to, just to comment that the lack of ACPs and limited multidisciplinary collaboration likely contributed to high rates of intensive medical treatment at the end of life. On to counseling. Encouragingly, 68 of the patients' families received well-documented comprehensive counseling with clear indication of family response. 8 families had no counseling documented, but it's important to acknowledge at this point a limitation of our study. We assumed that counseling didn't occur when it wasn't documented, although this may not have always been the case. At times, competing clinical demands may lead to counseling being provided, but not recorded. Just to go on to the specifics of what support was offered, 71% of the families in our cohort had social work involvement, and 32% had additional psychosocial counseling. Unfortunately, only 18% had CDG applications completed, despite the fact that many of the patients would have qualified for this grant. In terms of the last 24 hours of life, the overall picture is one of intensive invasive care near the end of life, often in the absence of structured advanced care planning. 64% of the patients were ventilated in the last 24 hours of life. 56% received inotropes, 65% underwent blood tests, and 70% remained on IV fluids. Among the PICU deaths, 57% had do not resuscitate orders at time of death, and 26% died following withdrawal of life-sustaining therapy. This indicates that families are receptive to conversations about the futility of continued interventions. In terms of hospice eligibility, 1/3 of the cohort would have benefited from hospice care. And these children,
1 minute left.
Okay, I'm nearly done. These children were often older and more likely to have congenital heart disease and oncological diagnoses. 90% of the children who met hospice criteria died in medical wards, suggesting that a hospice environment could have provided a more appropriate setting for end-of-life care. So just in summary, the study identifies several key themes. There's late engagement with specialist palliative care, limiting opportunities for holistic support, minimal advanced care planning, resulting in aggressive and often non-beneficial interventions, inadequate opportunity for multidisciplinary team engagement, PICU as the default site of death, gaps in bereavement support, often influenced by staffing limitations and socioeconomic barriers, and a large unmet need for hospice care. The study provides foundational data that can inform provincial policy, resource allocation, and strategic development of pediatric palliative and hospice services. Thanks for listening. I'd like to acknowledge my supervisors, the PedsPal team, and the families whose experiences shaped this work.
Thank you, Stacey. Any questions for Stacey?
I see there's one in the chat now. Yes.
Must I answer the question in the chat about recommendations for improved referral?
Yes, please.
That's a good question. I think ease of referring. We all know that, yeah, we have so many things to do, and sometimes this just falls at the bottom of the list. So I know that Red Cross actually has done a QR code. This was done actually after this study was conducted, but I think that's made a huge difference in terms of the QR code is right there. You just scan it, and it takes you literally a minute. So I think that's actually already been addressed somewhat.
Thank you for that. We have another question for Olubni.
In the chat.
No, I think he's raising his hand.
Okay.
Can ask you. Go ahead.
Okay. Let me tap to mute. Oh, la, la. Oh.
Can hear you.
Yeah, I've unmuted myself. Thanks very much for your presentation. One of your slides really caught my attention because we are talking of palliative care here, and the slide talks about interventions within the last 24 hours, and I saw some active interventions. So that actually makes me to want to ask a question that says, when did you make decision that this particular patient needs palliative care? If within 24 hours, you're still talking about blood, ventilation, inotropes. Yeah. So I just want to clear that, because my knowledge of palliative care means that, okay, decision has been made that nothing can be done here except comfort care, so to say. Thank you.
Sure. Thanks for the question. I think it's quite involved, the answer, but I think our understanding of palliative care has expanded a little bit more, and it's not necessarily, it's a spectrum, I guess, and it's not necessarily hands off completely, as is evidenced by sort of the ACT classification. The other thing that I think is important to acknowledge is that this was a retrospective study, and so I wasn't involved in the decision of whether the patient was palliative or not. And so we used the definition from Fraser and Parslow's paper for life-limiting conditions. And that was how patients were either included or excluded from the study. Not sure if that answers your question.
Good afternoon, colleagues. With the third theme this year of moving from crisis mode to solution mode, I've chosen to share my advocacy project with you, which I've titled Oral Health Meters, ensuring clinicians cover the road to health chart as a routine norm, referring to dentists preventing oral health diseases. This is to ensure we all get to play a part in advocacy every chance we get, as it is our duty as child healthcare practitioners. My name is Asanda, a medical officer at Victoria Mxenge. This is a reminder that we too have a role to play by lessening the burden of dental caries and oral health diseases amongst children under 6 years in South Africa to improve their overall quality of life, and so to keep their beautiful smiles through early dental referral. This is just a poster that was shared throughout the pediatric wards, dental department, POPDs, ensuring that the awareness was done not only to us as the healthcare providers, but also to the caregivers. So a bit of background: oral health continues to be a substantially neglected component of child well-being in South Africa. So recent global evidence does confirm that early childhood caries affects nearly half of preschool children worldwide. In low-income settings, untreated oral conditions drive systemic complications, yet national child health policies still overlook oral health integration. So this advocacy project basically reframes oral health as a constitutional right for children, not just as a peripheral luxury. So I just thought I should highlight that by neglecting oral health, a number of children's rights are neglected, as highlighted in the South African Constitution Bill of Rights, also the International Covenant on Economic, Social, and Cultural Rights, as well as the United Nations Convention of Rights of the Child, to name a few, highlighting that a child has human rights, and part of these include the two main ones: the best interest of the child, and that the right to health, specifically ensuring highest attainable standard of health is achieved, making this an inclusive right with timely and appropriate prevention, which I wanted us to focus on, as well as health promotion. This also includes the right to information, education, as well as non-discrimination that comes with it, and also their right to play when they are facing oral health issues. Now, neglecting oral health can lead to gum diseases, as well as bad breath, infections, including dental abscesses, which we've seen quite a lot, and eventually tooth loss, interfering with a child's right to health. Dental caries is the most preventable disease worldwide, according to the global disease burden. And yet it's still simply not mentioned in the general health sector design due to its failure to being promoted within the medical and allied health curricula. So a rights-based approach could strengthen oral health systems policy, elevating it to the sole inclusion of being a right to health context. The aims, there is obviously a huge gap in this. With this advocacy project, a lot of us healthcare practitioners, when I was finding out, it turned out a lot of us didn't know that we even had a role to play by early referral, as well as timeless access to oral health and dental health care for children. So education on the dental pages of the Road to Health chart, which is page 20 on the old one, and the current one, which is 28 and 29, will be as easy as educating the moms on oral rehydration solution, growth monitoring, prevention of mother to health, prevention, PMTCT, follow-up, as well as immunization schedule, which is a part of the national norms and standards, and it is a part of the Road to Health chart for a reason. So our aims, it was just to design, pilot, and assess a rights-based advocacy project through awareness, mainly integrating oral health, routine oral health screening, and timely dental referral by all clinicians seeing pediatric patients at all levels of care as their advocacy, which is an essential part of professional practice. So the message was quite clear, even on the posters, to do away with perceptions, as you can see. And also just a reminder of what this Road to Health pages, Road to Health chart pages look like. This is the old one on my left, as well as the new one on the page 28 on my right. There's also a page 29, which strictly highlights that from 6 months of age or from the first tooth eruption, you can refer a child to the dentist. So methods were simple. They were through multiple PowerPoint presentations. A lot of stakeholders were used through meetings involving the district specialist pediatricians, as well as the dentists in the department, in the hospital rather. And it's just to mention that we ended up also doing a dental outreach, which involved about 23 peripheries that our regional hospital was referring to. So this was Frontier Regional Hospital in the Eastern Cape. And a total of approximately 400 patients were seen on that day, and about 40% of those were children. So this is just a glimpse of just what was happening that day, where the awareness was done, also including the caregivers with the Kiddies Bible, as I would call it, the Road to Health chat, educating them about the importance of just saying the dentist is not about pain, but to refer the child early to the dentist as well for checkups.
1 minute left, Asanda.
Pardon?
1 minute left.
Thank you. So this was already highlighted, but just the importance that health promotion does lead to prevention of diseases, and it is way cheaper than treatment. So a lot of input was received from the staff, and it was used. So just a bit of the results. The project did lead to a measurable increase in dental referrals, strengthened the interdepartmental referral system, enhanced awareness of oral health as a right, as well as healthcare workers noting and prioritizing the page 28 or 20 of the Road to Health chart. So just in this graph, a quick highlight in the green above, that there were quite a lot of, there was an increase in new patients that went to the dentist and now coming for checkups, as well as posters that were seen, through the posters that were seen, and also around the wards. Sadly, there were still more tooth extractions in the orange highlighted. So the advocacy project, it is an ongoing project that I would like to see duplicated in multiple districts, and just us doing our part, because we see patients every day. So why not just refer when we see each patient? Thank you.
Thank you for that, Asanda. Do we have any questions for Asanda? I see one in the chat. Notando, you can go ahead and just ask your question.
Okay, I'd written it in the chat, but I'll say it out. Yeah, no, thank you so much for Asanda for the presentation. And I know, having worked as a healthcare worker, I know that most of us who are not dentists often know nothing about dentistry. And so many kids are missed because we don't know anything about it. So I just wanted to know, in terms of your content, what kind of content did you have? And did you also include nutrition, because it's a very big part of oral health? And what kind of cadres of healthcare workers did you include in your sessions? Thank you.
Okay, thank you for the question. In terms of the stakeholders involved, it was our pediatric unit in its entirety, so including our nurses, as well as our doctors, our district specialist pediatrician, also as well as our new dentists. So where we had found that there was an increased prevalence in children coming in with complications of the dental abscesses, we had actually an incident where we had also seen one who had complicated with a Ludwig's abscess, one which had complicated with a brain abscess as well, I think about 2 or 3. So basically it was a matter of saying that prevention is better than cure, and there is a role that we can play, because these children are seen by us more than they are seen by the dentist, and they only go there for the treatment. So if we were to refer, as is expected as per Road to Health chart, we would actually get to prevent a lot of these, and hence improving the quality of life for the children. Thank you.
All right, thank you for that, Asanda. We now go to Pranesha. Please present what you were going to present. Thank you.
Good afternoon, everyone. Thank you kindly to the organizers for your assistance and patience. Good afternoon to the distinguished speakers and fellow delegates. My name is Dr. Pranesha Appalsamy, and I am a specialist pediatrician working in a regional neonatal unit in KwaZulu-Natal. I sincerely appreciate the opportunity to present the journey my team and I have experienced in establishing a human milk bank, from its beginnings to the remarkable milestones we have reached. I will begin by presenting a concise background that outlines our aim and challenges encountered. Subsequently, I will discuss the innovative approaches we implemented, review the results from the data collected over several years, and conclude with key lessons learned. Next slide, please. So sorry, thank you. Next slide, please. To provide some background, we know that premature, low birth weight, or critically ill infants, breast milk is essential to protect against life-threatening conditions such as NEC, to promote brain development and growth, and to prevent deaths in neonatal ICUs. Now, vulnerable babies sometimes are unable to access their own mother's breast milk, which we know is best, due to medical complications or admission into an NICU. Next slide, please. Now, commercial milk formula is not an ideal option for these babies, as it can increase the risk of infections and other complications. In such cases, donated human milk, that is breast milk donated from another mother, can be utilized. There are currently 18 human milk banks in KZN. Our hospital established its human milk bank in 2017, despite many hurdles. So essentially, our aim was to establish a human milk bank in a resource-restrained neonatal unit. Now, to provide some context for our working environment, I included the total delivery rate for our institution in 2018 based on our PIP data. On average, there were approximately 1,000 deliveries per month, with about 15% of these infants being born preterm, underscoring the necessity for a human milk bank. Next slide, please. During our initial assessment, we uncovered several significant obstacles. One of our challenges was the unavailability of human milk bank assistant posts, which had been frozen and were no longer accessible for recruitment. Moreover, the absence of essential equipment compounded the difficulties in getting our milk bank up and running. There were no protocols or guidelines available, which meant that our team lacked a structured framework. Another major issue was the limited pool of maternal donors, a situation largely attributed to high rates of HIV and syphilis infectivity. In addition, there were cultural barriers and prevailing staff attitudes that contributed to poor acceptance of milk donation. We also identified the lack of systems for quality control from the lab, which posed a risk to ensuring the safety and reliability of donated human milk. Finally, the project faced a significant logistical challenge as there was no dedicated space allocated for the operation of our milk bank. Next slide, please. Please allow me for a brief interlude on this Friday afternoon to share my green pancake recipe. Now, as a working mom of 2 hungry and energetic boys, I'm always looking for ways to ensure their meals are packed with nutrients. And to achieve this, I have adapted the traditional pancake recipe to create an extra nutritious treat for them. In a similar manner, although we were familiar with the essential components required to establish a human milk bank, it was crucial for us to adapt these elements to suit the specific needs and circumstances of our unit. Just as I adjusted a standard recipe to better nourish my children, our team needed to modify the human milk bank framework to overcome unique challenges and optimize its effectiveness within our setting. Next slide, please. Our journey commenced with assembling a dedicated team of passionate individuals, which composed ENAs who were enthusiastic and embraced their new responsibilities as human milk bank assistants, as well as dietitians and a pediatrician. To ensure efficient workflow and clarity, we established well-defined roles and responsibilities. This thereafter grew as we expanded with lab staff and IPC nurses. Furthermore, we recognized the importance of seamless communication. To this end, we created a WhatsApp group enabling real-time communication. We included key stakeholders outside our immediate committee, such as matrons and OMs, to ensure broad support. Now, our next priority, next slide please, was to implement robust systems and structures to support the operation of the human milk bank. It was essential to ensure we had a dedicated area. This space would serve as a central hub for all activities related to collection, processing, and storage of donor human milk. To facilitate high standards of hygiene and effective milk handling, we procured the necessary equipment. We utilized the comprehensive provincial protocols and guidelines tailored to our local context for best practices. Accurate and detailed record keeping was instituted to track every aspect of the milk banking process. Next slide, please. And you can see these documents that we adapted to our unit. Finally, we prioritized the training of all staff involved with the milk bank. Training in sessions ensured that team members were well equipped with the knowledge and skills required to perform their roles effectively. Next slide, please. Now, due to the shortage of internal maternal donors, we utilized social media to identify external donors. These individuals resided outside our hospital district. Therefore, we coordinated with their local clinics to facilitate screening and blood collection. For example, one donor, Yvonne, is shown here. Blood tests were checked and reviewed on the NHLS system remotely, and if all results were negative and the donor met eligibility criteria, the clinic stored the donated milk for us until our hospital transport was arranged for collection. Next slide, please. After conducting multiple awareness campaigns in our wards, antenatal clinics, and even radio broadcasts, as well as providing recognition tokens to our doctors and nurses who were recruiting, we saw an increase in our internal donors. Next slide, please. As the amount of donor milk increased, it became necessary to ensure that the samples were handled and tested correctly in the lab. At first, the lab staff needed guidance about how to store these samples upon arrival. But over time, as you can see, with more milk being tested and clearer procedures in place, the number of contaminated samples shown in orange decreased. Next slide, please. One of our major challenges was resolving issues as they arose, such as our freezer malfunctioned earlier this year. Since repair or replacement wasn't immediately possible, we launched a fundraising initiative and secured a sponsored interim freezer for our team. Next slide,
1 minute
please.
left.
Thank you.
Thank you.
Over the past 8 years, both the number of mothers screened and new donors recruited have risen, along with the volume of pasteurized human milk. Notably, the number of new babies, next slide please, has also risen, even as the transferred milk that's coming in, suggesting that an increase in our total internal donor pool. In summary, what did we learn? We learned that you need to adapt your project, next slide please, to suit your specific unit while still maintaining standards. Teamwork is essential. Anticipate challenges, but be ready for them. To date, 96 donor mothers have contributed over 77 liters of breast milk, supporting 107 vulnerable infants in their survival and development. Next slide, please. In conclusion, I would like to share with you our liquid gold tree of life, where each golden leaf symbolizes an infant who benefited from donated human milk. Next slide, please. This initiative serves as a source of inspiration to all, highlighting the generous contributions of our donors and the heartfelt expressions of gratitude from recipients. I thank you for your attention. Next slide, please. I would like to acknowledge the wonderful people next slide, please, that I've worked with on this endeavor. And these serve as my references. I sincerely appreciate your attention and will take any questions now. Thank you.
Thank you, Pranesha. Any questions for her?
My name is Zandile Kubek. I'm in the National Department of Health. I am going to share with you the update on the revised integrated management of acute malnutrition guideline. So this is the update to the operational guideline of 2015. Many of you might be well conversant with the 2015 document. And the current version that we're trying to get signed off is the 2025 version. So the purpose of the IMAM guideline is to harmonize the approach in the prevention, diagnosis and management of acute malnutrition, to also present the recent evidence and best practice on the management of acute malnutrition, where we're also seeking to integrate management across all levels of care to ensure the continuum of care. The document also seeks to serve as a reference material that can be used to support operationalization and implementation of the guideline. So the target audience is for health managers and other relevant health workers who are responsible for medical, dietary, social, and rehabilitation of children with acute malnutrition. And the document is also very relevant for training institutions. The scope covers the management of wasting or acute malnutrition among infants under 6 months at the risk of poor growth and development, and also infants and children 6 to 59 months with SEM or MEM. And there's also a strong component in this version on prevention of acute malnutrition. You will also, when you get hold of the document, see that there's also a monitoring and evaluation framework together with other resource materials which are provided in a form of annexures. The 4 components of the IMAM guideline includes the community mobilization, a supplementary feeding program for children with MEM, outpatient therapeutic program for children with SM without medical complications, which is aligned to IMCI, and then the inpatient therapeutic program for children with SEM with medical complications. Just to zoom into some of the what is new in the guideline is the integration of the key principles of care, wherein we also now focusing on the multisectoral actions with the health systems at the center, wherein we're trying to also bring in the role of other key departments in addressing the social determinants of health. And also addressing issues around maximum coverage and access, of which we know that not all children are able to access acute malnutrition screening services, care and support. The key principle that is also very important is the ensuring of having nutritious home foods, which is a priority, and then also the multidisciplinary team approach and caring for the caregiver, infant pair with the focus on responsive care and focusing on the psychosocial support for the caregiver. These are the relevant global and local documents that informed the document. Then in terms of what is new for the to 6 months at outpatient or inpatient management based on an in-depth assessment, and then also the introduction of the cutoff points for mid-upper arm circumference screening below 11 centimeters to identify infants at risk of poor growth and development, classification of X-primes, who are also largely at risk of poor growth and development, with emphasis on re-establishment of effective breastfeeding and support for the non-breastfeeding mothers. If we look at the 10 steps of inpatient management as they have been presented initially by WHO way back, these have not changed by and large, but I'll just highlight a few areas where we can note, more especially with regards to step 4, that talks to correcting electrolyte imbalances, and step 6, correcting micronutrient deficiencies. Here, based on the new guidance from WHO, there is no need to add additional electrolytes and micronutrients if the children are consuming the ready-to-use therapeutic foods that comply with the WHO specifications. Then in terms of the step 8 that talks to transition phase in feeding to promote catch-up growth, there are feeding approaches that have been proposed either using F75 together with RUTF or using F100. The quantities of RUTF have also been reduced to provide up to 185 kilocalories per kg per day versus F100, which still goes up to 220 kilocalories per kg per day to promote a catch-up growth. Of importance is now the new guidance on management of moderate acute malnutrition, wherein it has now been seen that there is benefit in prioritizing specialized formulated foods interventions combined with counseling for children who live in high-risk context. Here we're basing this on the criteria of the mark indicated here, the weight for age Z-score below -3, children who are below 24 months, children failing to recover from MEM after receiving only counseling as an intervention, children who have relapsed, or those with history of severe wasting or comorbid conditions, including HIV and TB. So the implications for this is the need to have sufficient supplies and access to specialized formulated foods, because these should provide up to 60% of the total daily energy requirements needed to achieve anthropometric recovery. There's also the other group of the at high risk context children who can benefit from specialized formulated foods along with counseling and provision of food supplements. So these are children who are by and large in food insecure households, those with poor water sanitation, low socioeconomic status, and those in with high incidence of prevalence of malnutrition, those malnutrition hotspots. So there's also implications for this in terms of ensuring that nutritious foods are made accessible, affordable to these at high risk groups, or by and large for children under 5 years, which will serve as a preventative measure, because there's an assumption that a child will be taking a home diet that covers 100 kilocalories per kg per day, and then the specialized formulated foods will be topping up an addition of 25 kilocalories to support a catch-up growth. Then there's a component of community mobilization with a key focus on engaging and empowering communities by increasing their knowledge and understanding of acute malnutrition, active case finding, provision of appropriate IYCF nutrition education and counseling, as well as follow-up care of those children who are persistently at risk, and problem cases through home visits. There are key components outlined in the guideline about community mobilization activities. I will just go through the main headings, including your community assessment to understand the situation for those communities, the development and use of existing messages and materials, sensitization, a plan for the community, capacity building for community healthcare workers and other community-based workers, active case finding and referral, as well as evaluation of the effectiveness of the community mobilization activities. There has been considerations also for children with SEM who have comorbid conditions, including giving the same ART regimens as children with HIV who do not have a severe acute malnutrition, and also delaying ARV treatment until after metabolic complications and sepsis have been addressed. The use of the same therapeutic feeding approaches applies for children with SEM who are HIV uninfected, and also for those children who are TB uninfected. Then the issue of prophylactic vitamin A and zinc for management of diarrhea, as indicated for other children with SEM, is applicable unless if the children are already consuming the therapeutic foods that complies with the WHO specifications. Then importance of investigations to exclude carbohydrate intolerances and infective causes for children with non-resolving persistent diarrhea, as this group of patients may require different managements, such as modification of fluid and feed intake or the use of antibiotics. Then the other key one,
Sorry,
it's
Zandile,
children
the
with...
time is up.
Okay, should I stop here? Let me just wrap up in just a few seconds. Then there's also consideration for children with neurodevelopmental delays, which is unpacked on the guideline, and the prevention aspects, which I will not go through. I think the presentation will serve as something to share with the participants. And then we have annexures that seeks to support operationalization of these guidelines. My apologies for rushing through this. The time is just not so sufficient. Thank you so much.
Thank you, Zandile. Unfortunately, we don't have time for questions for Zandile, but there are questions for you in the chat. I think you can answer that.
Good afternoon. Sorry, technical errors and problems. I'm Dr. Iten Koliswa I'm working currently as a medical officer in Ituseng Community Health Center. I'm going to present my study for MED that I did in Tusong Hospital. Next slide, please. Hello? Okay, my title of the study was that factors that are associated with severe acute malnutrition in children under the age of 5 years at Tucson District Hospital in Northwest Province. So this my study was encouraged or was driven by the fact that I have experienced more death while I was working in a PEDS unit. So that's what driven me to do this study. So this is the index of my presentation, starting with background and ending with conclusion. Next slide, please. So for our background, remember that severe acute malnutrition has been identified as one of the 5 leading causes of death in children under 5 years, which was directly or indirectly accounting for about 30% to 50% of the death, according to the World Health Organization. And it stated that it remains a major public health problem. Factors with severe acute malnutrition in children under 5 years and the prevalence thereof in Tusong Hospital. Next slide, please. So the methods that we used was a descriptive prospective cross-sectional study, which was involving around 120 participants. The participants were calculated taking the previous year, which was 2019, which we admitted about 283 patients. So we used it as to calculate our participant. So what we had, we focused on the demographics of the children from age, the birth weight, and if it's a female or male. And then we also looked at the features where we were describing our severe acute malnutrition, which was edema and also wasted, described by a MWAC of less than 11.5 and also a Z-score that is below -3. We also look at the maternal demographics, which were the caregivers who brought the children to the hospital, and also we looked at factors that were socio-economic, whereby we looked at the family status economically, and also we analyzed. Next slide, please. So the result of our study, we found that we had a prevalence of around 35.8% of severe acute malnutrition. And then we noticed that most of our participants were male, contributing 58.8% with a mean age of 21 months. As I've said, our diagnostic features for SAM included those with edema and those with wasting. And then the wasting was measured by the MWAC, that is below less than 11.5, and there's a score which was below -3. So we've seen that there was also presence of comorbidities in these children, diarrhea, which contributed around 51.3%, and respiratory issues contributing 38.7%, though these were not statistically significant, but they were clinically significant. Next slide, please. So for the maternal characteristics, it revealed that most of the mothers were single and they were unemployed, and they had an income of less than 2.5. Majority of them were dependent on the SASSA grant. Majority of them were getting around 500 if they had one child. They were truly depending only on SASSA. So we found that all the above mentioned were not statistically significant, though they were clinically significant. Of note is that alcohol usage by the caregivers or the mother who brought the child was clinically and statistically significant, leading these mothers to neglect their kids. So those kids who had SAM, majority of them, their parents were using alcohol. Next slide, please. And then of note, we thought that, obviously mothers who are educated won't have babies with SAM, but our study proved us wrong that most mothers who came, they have attained a secondary school education, contributing about 71.2%. Although those with primary or no education, they were clinically and statistically significant. So we also seen that the household that contributed, where most SAM babies come from, were the household which comprised more family members of between 4 to 6 members, about 50% of our children. So a majority of this household, they had water and electricity. Next slide, please. So from our study, the findings highlighted a very high prevalence of 38% of SAM, and we saw that maternal alcohol usage was the major contributory factor, and those with primary or no education. So alcohol usage and low education needed special attention. Therefore, we adopted interventions where we had the SAM forum. We made a SAM forum which contributed, or which included the social workers, the traditional healers, the chiefs of the nearby villages, because we are also catering for villages and farms. Also had dietitians. It contributed the community healthcare workers. It contributed also the doctors from the institution, the nurses, and the operational manager of PEDS. Next slide, please. So as I've said, so this also, on our forum, we also encouraged those mothers who were, because majority of them were young, we encouraged them to attend school so that they can later be employable, so that at least it can reduce the problem of money. Next slide, please. So this insight that we have received informed us as healthcare workers, and it can also inform the policymakers to develop targeted interventions to address malnutrition effectively. Although many researchers have attempted to devise strategies to address this severe acute malnutrition, more work needs to be done. So further researches and interventions are needed to prevent early detection of this SAM, address the socioeconomic determinants of life in our community and manage severe acute malnutrition. Ultimately, therefore, we're going to improve our child health outcomes. I'd like to take this opportunity to thank my supervisor and also the team that I worked with. Thank you very much.
Thank you for that, Elizabeth. There's some questions for you in the chat. Please answer them. And I think we'll go to our last presentation from Bhavani. Thank you so much.
Good afternoon, everybody. Thank you for having us. My name is Bhavani Vandya. I'm a medical officer in the pediatric department from General Justice Dzinga Mpanza Regional Hospital in KwaZulu-Natal. And today I'm going to be presenting on one of our new QIPs in our nursery, doing more with less, a low-cost, rapid solution for gastroschisis management in a resource-limited regional hospital.
Sorry, can you just put it in presenter mode for us?
Okay, is it now in presenter mode?
No. Not yet.
Sorry, just give me 1 second. Now?
No.
Okay.
I think if you make it bigger for now, we'll, in the interest of time, I think we should just carry on. So just go ahead, it's fine.
Okay, sure. Okay. Can you see the presentation?
Yes, we can. Go ahead.
So gastroschisis is a neonatal emergency. It is a full-thickness abdominal wall defect resulting in herniation of the abdominal viscera. Although the incidence of gastroschisis is variably reported, there has been an increase in the prevalence over recent decades, approximately 4 cases per 10,000 live births. These cases are not uncommon in the Ilembe district, as we have experienced at our facility, given the risk factors linked to gastroschisis, such as young maternal age, low socioeconomic status, cigarette, marijuana, and alcohol use. And due to poor antenatal screening, the majority of cases are diagnosed post-delivery, ultimately resulting in delays in bowel coverage and consequently further complications. In an ideal setting, there would be an antenatal diagnosis and a planned delivery in a tertiary center with an NICU and pediatric surgical services. However, in South Africa, we face challenges with regards to poor antenatal screening and diagnosis, as well as our tertiary centers lacking bed space, which can lead to significant delays in transfer. And so until then, time is bowel and early bowel coverage is important, especially to avoid complications such as fluid loss, dehydration, hypothermia, sepsis, organ injury, and bowel ischemia, as demonstrated in the picture.
Sorry, Bhavani, your slides are not advancing now. Sorry.
Sorry. Okay. Maybe, okay, let me stop sharing, and then let me start it again. And I can't go and share. So
Okay, it's currently on slide 5.
Slide 5, okay.
It says our aim.
Yes, okay.
Thanks.
So Our aim is to improve the outcome of all gastroschisis cases by decreasing the mean time to bowel coverage and to do so in a cost-effective manner, and to also eventually share this initiative with our district hospitals. So our solution was to assemble a gastroschisis box which contains all necessary equipment required for making a low-cost functional silo bag. Unfortunately, we do not have access to formal silo bags, and we are unlikely to get them at a regional level as they cost an upwards of 5,000 rands. So on multiple occasions prior to this QIP, some of these items, particularly the 500 ml vacuoliter and correct size urinary catheters, were not readily available, and we would have to search through numerous wards until we could find them. This is especially difficult and tedious after hours when we are short-staffed and have a busy unit with ill babies. So as one could imagine, this can cause a significant delay in attending to bowel coverage.
Sorry,
So
we're not seeing your slide. It's not advancing. So we're still on slide 5. Do you want me to try share? All right, we see it now. Now you're on slide 7. The contents of the box.
7, okay, sure.
Yeah, so I think just as you go through, you're just going to have to manually move it. Sorry.
Okay, no problem.
Cool.
Thanks. The contents of this box includes various sizes of vacuoliters, 200 ml, 500 ml, and 1 liter, various size silicone urinary catheters, 16, 18, and 20 French, 2O suture material, sterile blades, and adhesive foam dressings, as well as a copy of instructions on how to construct the silo bag. So the steps to construct the bag are fairly simple, and we'll just go through them briefly. However, they can be found on the UCT or Cape Town Neonatal Guidelines. So step 1 is selecting an appropriately sized vacuoliter, which would be in relation to the size of your defect, to cut the base and to empty the fluid out. Step 2 is to cut the urinary catheter, approximating the diameter of the vacuoliter opening. Form a ring with the catheter by inserting the catheter tip into the cut opening or by fastening the ends together with an adhesive. Step 3 is to position the catheter ring around the open base of the vacuoliter. And step 4 is to fold the edges of the vacuoliter upwards and over the catheter ring and then secure it in place by suturing. Step 5 is to place the bag over the defect and then secure it to the skin with adhesive dressings. And step number 6, the last step, is to elevate, so with using a piece of string, keep the bag elevated by tying it to an overhanging structure, which is a very important step as the elevation aids with the bowel perfusion. So before concluding, we'd just like to mention that this is a new QIP that we have implemented, so we cannot comment on results as yet. However, in the future, our goals are to assess the incidence in our district of gastroschisis cases and to also follow up these patients and their outcomes. So to conclude, in a resource-constrained setting, a gastroschisis box can offer preparedness and high-quality care without specialized equipment and with no additional funding costs. It is simple innovation that is reproducible, sustainable, and embodies the principle of doing more with less. Thank you.
Thank you, Bhavani. Very interesting and innovative, as Notando said. Does anyone have any questions for Bhavani? All right. If there are no questions, thank you so much for attending the conference, and thank you for your research. It's very impactful. I don't know if Denise has something to add.
No, just to thank all our presenters and everybody who stayed with us this afternoon. I know we ran over time, so thank you to everybody for participating and being with us. And from my side, have a good Friday and a good weekend. Thanks.
Thank you, everyone. Goodbye.